Welcome to Med Practice Made Perfect, brought to you by Practice First Medical Management Solutions. My name's Tom Maher, and I'll be your host. In today's edition, we're going to discuss key performance indicators. So, key performance indicators, also known as KPIs, are metrics that are devised to gauge the health of your medical practice from the standpoint of finances. So, over the years that I've been, working on medical practices, there's recognized metrics that, a lot of folks use. And, I think you always want to start out with the most basic key performance indicators first, and then you can get a little bit fancier as time goes on. But it's not just about, running numbers and seeing what the number is and comparing it to, what your past experience has been, but trying to figure out what's driving those numbers, and what can I do to improve, or in the case of finding denials, what can I do to reduce the error rate, those sorts of things. So the first one I'll start out with today is a very basic one. What is my average charge per encounter? So on an average charge per encounter calculation, is very simple. You just take your monthly charges, which are your customary charges for the month, divide it by the number of chargeable medical encounters, come out with an answer. The answer is your average charge per encounter. Fantastic to take all of these KPIs and track them and watch them month after month to see where they're going, and develop a history of where these metrics lie. So that's the first thing to look at. The second thing to look at is what is my average receipt per encounter? So an average receipt per encounter is maybe a little bit more telling, because now we're not talking about customary charges like we were in the average charge per encounter. So what we're talking about here is, okay, what are my receipts for the month? And instead of dividing by the current month's encounters, we're going to divide by the previous month's encounters. Let's assume that we have 30 days in our accounts receivable. Basically, we turn our AR over every 30 days. Last month's encounters are what we're getting paid for this month. So again, simply, your total receipts for the month divided by your total encounters the prior month. Now, obviously, if you had a 60 days in your AR, you would use your encounters from 2 months ago. So that's a nice gauge, so you can kind of see how things are trending. Very important to look at this number month over month to see how it's trending. You also want to take a look at it, really good to look at it year over year and what the average amounts are for the year. The third KPI is collection ratio. So what we're trying to achieve here is we're trying to find out, for every dollar that we bill, we've set a customary charge for each CPT code. For every dollar that we bill, what are we actually yielding in a cash receipt? So let's just say that we have our fee schedule set at 3 times Medicare, just to use an easy number. So for 3 times Medicare, and we're getting paid, half of that amount, our collection ratio is going to be 50%. So how do you calculate this collection ratio? It's not as easy as just saying, well, I'm going to take, I can't take my current month receipts and divide it by my, current month's charges. I mean, that's not going to work out to be an accurate number because of fluctuations in your charges from month to month. So what you want to do here is you want to take your receipts and divide them by your receipts plus your contractual allowances on those same receipts. So it's your current receipts divided by your current receipts plus your contractual allowances. So that's going to give you a number. In the previous example that I used, that number would be in the neighborhood of 50%. So, or 50 cents on the dollar. So the idea here is that you want to keep an eye on how is that number trending over time. Again, you want to drop all these numbers into a spreadsheet and track them month by month, and you want to see if your number is improving or if it's or if it's not, and really try to figure out what's going on. Maybe there's some certain lines of claims that you weren't aware of that are being denied, that who's ever doing your billing didn't let you know about, and all of a sudden you're not getting paid on everything that you thought you should have. So the collection ratio is a nice thing to track, very important to track. Okay, so for the fourth KPI is days in accounts receivable. Okay, so what does that mean? I mean, days in accounts receivable basically means that how long does it take me to get paid from the time that I perform the service? So it's not, there's a bunch of factors that are involved in that, but the most important thing is how quickly do we get the claim out the door, and then how quickly do we get it paid? So this calculation is it's not a difficult calculation, and I'll give it to you kind of in two parts. So the first part would be that your numerator is going to consist of your last 3 months charges, and then what we'll do is that, and those are customary charges. Then we annualize those, so multiply them by 4 and then divide them by your ending accounts receivable. Okay, when you do that, the answer there, the quotient, is going to be your that's going to be your AR turnover rate. So what that means is how many times during the year is your accounts receivable turning over. So you take that one further step, is you take the number of days in the year, 365 days, divide that by the quotient, and your answer is going to give you the number of days in accounts receivable. So obviously, the shorter days in accounts receivable, the quicker you're getting paid, the better your cash flow is. So very important to monitor this month by month to see what kind of issues may be cropping up, or what you're doing better. So, a real simple example here of that calculation would be, let's just use very easy round numbers. Let's say that you have $1 million of charges each month. And let's also say that your open accounts receivable at the end the end of this period is $1 million. So if we take your charges, $1 million a month for the last 3 months is $3 million. Annualize that, that's $12 million. We divide the 12 million into 1 million. The answer is 12, right? So that is your AR turnover rate, 12. So that means 12 times a year your AR turns over. Then you take that AR turnover rate, and you take your number of days, 365, divide it by your AR turnover rate of 12, and your answer is going to be 30 days. So basically you have 30 days in accounts receivable. That's good. A good healthy practice, anywhere from typically 22, 23 to 35 days, and there are a lot of factors that drive this number up or down. It's really difficult to compare this statistic, this metric, practice to practice. It's very important. What's the specialty of your practice? You can't compare a primary care practice to a specialist practice. That just doesn't work. The numbers are not comparable. So also, what's the difference between maybe an inner city practice versus a practice out in the suburbs? If you're higher Medicaid population, Medicaid typically doesn't pay as quickly. You're going to have more days in accounts receivable. So all those factors really, are really important in the days in AR calculation. The fifth thing to look at is you really want to do like an AR agent analysis. And in the AR agent analysis, what you're looking at is your agent you're going to look at the end of the month. It's basically a snapshot where your practice is, who owes you what, and how old are the claims. So basically what it does is your typical buckets are current, which is 0 to 30 days, then 31 to 60 days, 61 to 90 days, 91 to 120, and 120 plus. That's typically the way that you want to break it down. And then what you want to have it broken down by is you like to have it broken down by major carrier. So whoever the major carriers are in your area, have those broken down. And really what you want to see when you're looking at this is you want to see, really your 90 plus, everything over 90 days, assuming that you have some patient population in there as well. You want to not look at just your insurance, but you want to look at insurance and patient, your total AR. You really want that to be less than 25%. I mean, ideally you'd be in the 15 to 20% range. There's always factors that drive these things up. Workers' comp, no fault, those things sometimes take quite a while to pay. But you want to look at your accounts receivable to see if there's issues inside the AR. So, how do you see that? So, when you're looking at an AR report, obviously your current stuff should be the largest balances. So as you move your eyes from left to right on the page, and you're going from the lowest, the most, the newest AR to the oldest, you want to see those numbers continuously decreasing. So, a little something to look for is that if you have a situation where it's not decreasing all the way across. So, what'll typically happen is, if you have a problem inside of your claim submission, I'll give you an example. Let's say that you have, um, you know, 50% of your aging for a carrier is current, and then the next bucket is 10% in the 31 to 60 days. And then all of a sudden, in the next bucket, you've got 20% of your claims. So that number should not be going up. So so then you got to investigate what happened. So, I mean, things that could have happened. I mean, maybe for some reason the claim submission that you made a couple claim submissions during that month maybe didn't get through. Maybe the person following up did not follow through to make sure that those claims got resubmitted, and maybe they all got rejected by a carrier. Maybe half the batch got rejected. So what you're checking for is breakdowns in your processes to make sure that the folks that are doing the work are following all the steps. And those things should not happen, because they should be followed up on right away if you're on top of it. So those are the things to look at in an AR aging. Okay, so the sixth metric that I like to look at is that how long does it take to get a bill out? So, there's a few factors in this. How quickly does the provider finish the note? And then once they finish the note, does it need to be coded? How long does it take to get coded? And how long does it take it to finally get billed? This is a relatively simple report to run out of most softwares. Basically, what you want to do is you want to look at a report that just says, okay, for the last month, what date did the service occur and what date was the claim actually filed? And, very easy to do a calculation. Okay, well, the service was performed on February 20th. The claim didn't go out to the 25th. Okay, you do a very simple calculation there. We've got 5 days, whatever the number is, and go through that for all your claims for the month, and then average all those things out and see how long it's taking you to get the claims out. And obviously, if you've got 30 days in AR and it's taking you 5 days to get the claim out, if you can shorten that time frame up, finish your notes the day that you saw the patient, make sure that the chart's coded the day after. And the day after that, there's no reason to submit, not to submit the claim. Really, what you should be looking for is about 3 days is typically an average amount that it should be sufficient to get the work done, and it's reasonable to get the work done. So everybody should be happy in that scenario. So in that simple example, 1/10 of the time on a 30 days in AR is spent, not even out the door yet. So that's an interesting thing to keep an eye on. Make sure that you don't lose control of your front end. So the seventh metric is your claims denial rate. So this is a very simple calculation. Basically, all you're doing here is most folks are submitting their claims through a clearinghouse. So when you submit, if you submit 1,000 claims to the clearinghouse for the month, how many actually got through? If all of them got through, I mean, you've got 100% success rate, zero claim denial rate. So, if you've got, if 100 of them got hung up, I mean, you've got 10%, claim denial rate. I mean, not good. That means somebody's got to go back in, work that claim to get it out the door, to get the payer to accept it. More important to this, so I mean, you want this to be down in the 2% range. And again, it depends on your practice. If you're controlling where the demos are coming from, you're not reliant on a facility where your people are collecting it, you can control that front end. Make sure that you're getting good eligibility information. Make sure that your folks are checking before the patient comes in that insurance information is good. You should really be down below 2% as a general rule. And most importantly, that whatever is causing the problem, you're going to take a look at and see if you can lessen that issue. Okay, so the next uh, piece of information to look at here is not so much a KPI, but you really need to take a look at your claims denials every month by type. So you're going to get denial codes back for maybe an entire claim, maybe certain lines on the claim. So what you have to do is record those codes into your system, and then take a look at the end of the month. Take a look at and run all the denials by type. And obviously you want to take a look at what are my most recurrent denials, and see what you can do to fix those things. I mean, it could be a coding issue. It could be it could be a few different things, but whatever the issues are, you want to try to fix those. Maybe you need to talk to the carrier to rectify it, but again, you want to make sure that you do this. A lot of times what you'll find is these things are carrier specific, and you want to make sure that you're coding in accordance with your carrier contracts. If there are some peculiarities between each of your contracts, to make sure you lessen these denials. Okay, so the next metric to look at is, what is my net collection rate? So it's a little bit different than what we talked about earlier. So what we're trying to determine here is, of everything that we billed in the prior months for these payments that came in, what was, did we get all the money that we were supposed to get? So, if the customary charge was $100 and we were supposed to get $50, how much of that $50 did we get? So, maybe there was two CPT codes that led to that $100 charge. Maybe we only got paid on one of them. Maybe there was a denial for something that they didn't bother to follow. Your folks didn't bother to follow up on. Where the entire charge gets written off. So, I mean, in this instance, it's a little bit difficult to track because you've got to be careful as to what the biller's doing and how they're posting these denials. But in a typical world, really what you're looking at here is that what what percent of the total allowable amount that I actually received from what was possible. So I mean, there's certain things that you can't control. You can't control a charity care write off, and that sort of a thing. So basically, what you're trying to do is you're trying to develop, well, how much should I have gotten paid, and how much did I actually get paid? So the way that you find this is if everything is posted properly, which is sometimes a big if. You look at your different write-off codes and you set your write-off codes up so that it tracks some of the small things that, so it doesn't all just end up in a in a contractual allowance scenario where, all that should really be in there is the difference between what the carrier allows and what you charge. And there's other areas of write-off. So, I mean, there should be a write-off for, bad debt. There could be a write-off for charity care. There could be a write-off for non-covered service. Maybe you needed to have an ABN and you didn't, so you can't bill the patient for this. There's different things out there that can give you an idea. And again, this is another percentage that you want to track month after month. You really want this number to be in the neighborhood of 99% of what's available out there. You want to have collected. So, very important to not just track monthly, but also, over time. Okay, so the last metric I'm going to talk about today is something that you can track this monthly, but really what you want to do is you really want to track this on an annual basis. And what I'm talking about here is you really want to track your mix of business. And so, okay, why is that important? I mean, there's a lot of reasons why, this is important. I mean, is your practice aging? Over time, if you're not, paying attention and you're not attracting new patients, as you're getting older, your patients are getting older. Instead of being on commercial policies, they're now going to be on, Medicare policies. And you're trying to figure out why you're making less money. Well, you're getting paid from a carrier that's not paying as much as a commercial carrier might. So really what you want to do here is I would say to do this, you at least should look at this. You can look at it every 6 months, but let's just say annually. Because it takes a little time for these things to change. For a demographic to switch it switches over years. And I'll give you a perfect example. During COVID, the government waived the income eligibility for Medicaid patients. So the pandemic hit the end of March. May, I believe it was, or June, they waived they waived the income eligibility for Medicaid, and people that might have been making $250,000 each, a married couple making $250,000 each, all of a sudden they're both out of a job, they both qualify for Medicaid. They don't have to carry their COBRA. They're on Medicaid, and I believe the government didn't start income qualifying again until 2023. So we saw some pretty weird things during the pandemic where, 15 years ago, I analyzed an account in a certain area of the country that was, 7% Medicaid. And in 2021, they were 38% Medicaid. So it had a devastating effect on the particular practice I was looking at. But, as we come out of COVID and so forth, that's beginning to switch. And those folks are falling off the Medicaid rolls back on commercial plans as they get gainful employment and have to take the coverage. So again, what you want to do here is you want to organize all of your business into all of your claims into really a few different buckets. You want to take all of your commercial carriers and put them in one bucket. And again, what you're looking at here is you can look at this. You can look at it two ways. You can look at it by visits or you can look at it by charges. I would look at it by charges. So put all your commercial business together, then aggregate all your Medicare and all your Medicare lines of business for managed care plans from insurance carriers, and then also segregate. You can put together your comp and no-fault claims as another bucket, and lastly, you're going to put together your Medicaid, all your Medicaid plans. So your state straight Medicaid and all the Medicaid managed care plans. The last bucket you could have would be your self-pay bucket. So really what you're looking for here is what is my breakdown of business, for the year, and how did it shift from the year before? So you can go back into your practice and run these reports to say, okay, well, give me this information for, 2018, 19, 20, 21, 22, and you can see how your practice is tracking. So basically, the folks that you're caring for, who are the people that are coming in? How often are they coming in? I mean, it's going to be reflected because again, what you're looking here is not just your patient mix, but your actual, the actual mix of the work that you're performing, day after day, year after year, and who are the people that are actually utilizing the services. So, and that you're gaining a fee off of. So. Obviously, as I mentioned earlier, if you're shifting to Medicare and you're not attracting many new patients, your average receipt per patient is going to go down. Same thing would happen as if you're switching from commercial to more Medicaid business, less commercial. You're not getting paid at your highest rate. You're getting paid at the lowest rate. Going to have an impact on your practice. And there's not the first thing is you got to be aware of it. And what are we going to do? I mean, is there a way to attract younger people that have good commercial insurance to your practice? Sometimes that's easier said than done based upon the location of your practice. It's obviously important to be in a position where if you can have multiple locations, maybe you spend more time at locations that are a little bit more profitable to you. See this with practices all the time, where they're expanding hours in one, decreasing in the other. Maybe they started out in one section of town and morphed over to two or three other sections, and that's where you want to spend your time. You want to spend your time in the most profitable spots. As a summary, all of these metrics, standing alone, all by themselves, they don't mean a whole lot. I mean, they're just numbers. You really have to look at them, and you can compare these things to national numbers that you see for your specialty. But the most important thing is to compare it to yourself. and compare it to your past history of what you've what you've achieved in the past. So working on those factors to to help repair and make your practice a little bit healthier. Anybody that has any difficulty or questions? I know we went through a lot of stuff today that might have been better served on a whiteboard. My email address is tom@pracfirst.com. You can email me at any time, and get a hold of me and ask me the question. My phone number is right on the website and on my email. When I respond, happy to discuss it with you and help you out any way that I can. So I hope you enjoyed this version, and I will see you soon. Thank you. Thanks for listening to Med Practice Made Perfect.